So I was privileged enough to have attended the very initial workshops that were conducted by Nico Pils, Bernard de Bryan, and William Ferron in Nice, France. And these are the three main guys who did a lot of work on FFR, and they came out with all the initial trials that validated FFR as a useful tool. So what is FFR? That's fractional flow reserve. That is the ratio of hyperemic flow in the stenotic vessel to hyperemic flow in the same vessel, but in the absence of the stenosis. So if you want to put it in an equation, that means it's the maximum flow in the presence of a stenosis divided by normal flow, normal maximal flow, which means that if there was a stenosis, you want to see the ratio of how the blood, the maximum flow that would have gone in the artery, in the coronary, if there was no stenosis, versus the flow that is now going into the coronary if there is a stenosis, the flow that is going across the stenosis now. So it's the ratio of these two values. So putting it in equation, FFR is equal to myocardial flow in the presence of stenosis divided by myocardial flow under normal circumstances. Now, we do know that flow is equal to pressure over resistance. And if we can somehow remove the resistance from the equation, then flow will become equal to pressure. Now, why do we need this? Because flow is relatively difficult to measure. It is being used, it is being measured under the controlled environment in the research laboratories, but for practical purposes and day-to-day routine, flow is difficult to measure. We need some other surrogate to measure flow. So if flow is equal to pressure by removing the resistance, then it means that we can measure pressure, and that will indirectly tell us the flow. So at maximal hyperemia, flow is equal to pressure, because at maximal hyperemia you have nullified the resistance. And how do you do that? You achieve maximal hyperemia by removing resistance from both epicardial vessels by using nitrates and from the microcirculation by using adenosine. That's why nitrates and adenosine are both mandatory for FFR. So you can say that FFR is equal to coronary pressure in the presence of stenosis divided by coronary pressure without stenosis under normal circumstances. So FFR is equal to PD over PA, where PD means this is the mean distal coronary pressure at maximal hyperemia. So this is the pressure that is being measured by the pressure wire sensor, which is now present distal to the stenosis, and PA is the mean aortic pressure at maximal hyperemia, which is being measured by the guide catheter tip. And both pressures are measured under maximal hyperemia, because remember, we have to remove the resistance from equation. Just to give you an example, that's the PA. The guide catheter is measuring a pressure of 100 millimeters of mercury, and across the stenosis, the PD, that's the pressure wire sensor, that's measuring 70. So FFR is equal to PD over PA, means 70 over 100, that's 0.70. Now, what does this number 0.70 mean? So 0.7 means that due to this stenosis, maximum achievable blood flow to the myocardium supplied by this artery is only 70% of what it would have been if this coronary artery was completely normal. So now, instead of 100%, 70% blood flow is going across the stenosis. That is FFR of 0.70. Now, what you see on the graph is you've got a waveform, a red color and a green colored waveform. Now, red color is coming from the catheter tip, that's the aortic pressure or PA, and the green one is coming from the distal wire sensor, and that's the PD. And what you also notice is there is the waveform which you have to look at, and we will discuss this later. And at the same time, there is this horizontal line going in between, and these are the mean pressures. So mean PD and mean PA, and this is what you actually measure under maximal hyperemia and then put it into the equation to get the FFR number. How accurate is it? So when you use a value of 0.75 or less for FFR, the sensitivity is 88%, but specificity is 100%. And this value has been validated against a gold standard of reversible ischemia composed of all non-invasive tests, including exercise tolerance test, thallium scan, stress echo, against all of these. So if you use the value of 0.75, then anything below that is significant stenosis and you can go ahead and stent that. But if you use a value of 0.80 and above, then that is non-significant and you can safely defer this. But what about the value between 0.75 to 0.80, which is a gray zone and can be decided based on clinical evaluation? But a consensus statement of the SKY came out in 2013, which I'm going to read for you, that FFR was first validated using a cutoff value of 0.75. With further experience with the technique, investigators appreciated that by extending the cutoff value to 0.80, the sensitivity of FFR could be improved without greatly compromising the specificity. For this reason, a cutoff value of less than equal to 0.80 was used in FAME 1 and FAME 2 and shown to be clinically valid. This is now the recommended ischemic reference standard for the invasive assessment of myocardial ischemia. So now the cutoff value that you use for FFR is not 0.75, but it is 0.80 or less for significance, and anything more than 0.80 is functionally non-significant.